Everyone. I think we're recording. Perfect. So good morning, everyone. Welcome to our third clinical session on optimization strategies and workflow in the Expand system. It looks like we have an excellent turnout again. So I really appreciate everybody joining, and I hope that you find that these sessions are helpful and that you get some good information from them. So our first two sessions focused on documentation, tricks and tips, as well as we did some efficiency tools such as widgets and flow sheets and order entry. Today, we're going to talk about the admission and discharge process, that dreaded managed transfer, as well as medication reconciliation, BPMH, med reconciliation on discharge, and your discharge prescriptions. And Jill is here today to do the pharmacy medication reconciliation aspect of it. She does a great demonstration of that. So she'll be doing the latter part of the presentation, and I'll do the first part with regards to the admission part. So it should be lots of information for you today. Once again, we welcome questions in the chat. We'll try to answer those as we go along, and we'll open it up to questions at the end of the presentation so that the recordings will be cleaner for people who want to watch them at a later time. So please write down the questions and ask them at the end, or ask them in the chat. And once again, the sessions are recorded. The links are at the bottom of the presentation, where you can find the recordings and the tip sheets. So today we're going to talk about the admission process. I will go through some of the concepts here with the admission process, focusing, of course, on the admit, manage, transfer aspect, the med reconciliations, and then the discharge process. Jill will go through that and talk about some of the things to be aware of when you're doing the discharge medication reconciliation and discharge script, finalizing, and things to look for with home medications and when changes are made. And then if we have some time, we'll talk a little bit about Prescribe IT. Okay, so what I'm going to do now is I'm going to close this presentation window, and I'm going to open up my Expanse window. And then from that point on, we'll just keep the Expanse window open, and we won't be using the slides, but they're there for your reference, and that's where the tip sheets are. Okay, Maggie, just quick confirmation that you can see that okay?
We can.
Beautiful. Okay, so we're going to start off. I'm going to use this patient here. A discharge demo is the patient that I'm going to use. And one thing I want to point out quickly here is on the tracker, you'll notice this column here that has medication reconciliation. You see some are in green, some are in red, and that's important. And I'm not sure if people have noticed that or if they use that regularly, but it has a lot of downstream benefits, especially if you have a pharmacy tech or a pharmacist, or somebody tasked with doing your best possible medication history or your BPMH, because you can see quickly whether or not it's been done. So you can see here that the home medications have been complete here. We got our BPMH and it's been verified, versus here if it hasn't been done yet. So this is a really important column, and what we often will do is our pharmacy techs or pharmacists who do the medication reconciliation have a tracker that shows them this, so they can see which ones still need to be done in the emergency department. And it's really important that you try to triage it so that it's the ones that are going to get admitted that get their BPMH done first, rather than doing somebody who may not get admitted, and the ones that do need to get admitted are not being done in a timely manner. So that's an important column to keep an eye out for. All right, so we're going to jump into our patient here. We're going to focus just on the admission and discharge process. So this patient's in the emergency department. I saw them. They've been diagnosed with atrial fibrillation. They're just not feeling well with it, so we're going to admit them to the hospital, and then take care of them in there, and then we're going to discharge them. So my plan is to admit this patient to medicine. We're going to control their rate, put them on some anticoagulation and some rate control with metoprolol, hold some of their medications, and yeah, they get them admitted. So the admission process, of course, is through order entry. So when we go into order entry, we're going to be presented with our usual screen that we're familiar with. However, when we do the admission, we do it through the transfer admit. And this is the managed transfer that I'm sure everybody's familiar with. And that's where you do your admissions. So I'm going to click on transfer admit. And it's going to bring up my managed transfer. Now, what I want to do, just to kind of make this more real, in terms of how it would actually be in a clinical scenario, I want to add my medications here as though I've given them in the emergency department. So I'm going to give them their metoprolol, and we'll put them on 50 milligrams BID, and I'm going to put them on the Abixaban. Okay. So we've done that. So I'm going to submit that. Now I'm going to go and do my admission. So I've seen the patient, I've rate controlled them, I put them on blood thinners, they're feeling better, but they're just not ready to go home. So we're going to go ahead and admit them. So I'm going to go into my transfer admit. Now this patient's already had their BPMH done for me, which is great. And that's really a key part of efficiency in the admission process, is making sure you have the best possible medication history done for you. I know that's not easy for sites that don't have a dedicated resource for that, especially sites that, smaller sites that are very busy and you're playing multiple roles. And it's hard to get this done sometimes. But physicians, need to have that in there as soon as possible, and it needs to be, verified so that we can get the admissions done efficiently. All right, so we're going to admit the patient from the emergency department, and we're just going to put ours on the medicine floor. So this is going to depend upon what you have at your site. And we're going to go through and now do the reconciliation. So what we need to do is decide what we're going to do with our home medications that the patient's on, and then what to do with the medications that the patient's had in the emergency department. So we're going to do this reconciliation process before we go into adding any new admission orders. So the admit transfer has three parts: reconcile, then you add new, then you preview. So it's really important to do it in those three steps. I find people will sometimes jump in and reconcile the home meds before they go into managed transfer, and then they go and add things afterwards. If you keep it to the steps of reconcile, clean up everything from the emergency department, get their home medications sorted out, then you add the new orders, the new admission sets, preview it, and submit it, then I find that process works a lot cleaner. Okay, so we're going to go through their home medications. So they're on aspirin, 81 milligrams daily. Well, we're going to put them on Abixaban and stuff, so we're going to hold that, okay? Their amlodipine, yeah, sure, we'll continue that for their blood pressure. Now you notice here how it drops down and opens this box up. We can't control that. And one of the things physicians find is that's really annoying, because you have to then scroll down more. So one thing I'm going to show you that sometimes makes things a bit faster is if I unclick that and you go down to the bottom of your home medications and you start doing them from here up, sometimes it's faster because you don't have to keep on scrolling. So if I have my Ventolin, I'm going to continue that. Then I can go up here and do my Lipitor or whatever that is, one of those statins. Hit continue. And you see now I don't have to keep scrolling down. I can just get the one next above it. So I'm going to continue my Ramipril, and then I'm going to hold that naproxen, and I'm going to hold. I continue my PPI, my Nexium, and I'm going to continue my puffers, continue the amlodipine, and hold the aspirin. So you can see it's a lot easier if you do it from the bottom up, so you don't have that box keep on coming up that you have to scroll down. So that's my medications there. And now I'm going to go take a look at my visit medications. So from the visit medications, the only two things I started in the emergency department is the Abixaban and the metoprolol, right? So of course, we're going to continue the Abixaban on the admission, and we're going to continue the metoprolol on the admission as well. Now that I've cleaned up everything we've done in the emergency department, you may have IV fluids here, you may have, pain medications or anti-nauseants. And now similarly, you can continue them or stop them so that they're no longer going to take part as the admission orders. Now I'm going to go ahead and add new. So this is where I'm going to add my new orders for the admission, and I'm going to do my admission here. So we use our admission order sets. There's lots of order sets for particular conditions. Just to keep this clean, I'm going to use the admit med surge, but there is an admission order set for atrial fibrillation and for everything else. So I'm going to put Garnus here because I'm going to be the attending. The diagnosis is atrial fibrillation. And depending on your site, just the reflex orders such as the MRSA and swabs that need to be done, my standard diets. I want to make note of the handover order. So this sometimes has come up, and I'm sure people have noticed this now since we've been in the system long enough. But this is really nice if you want to hand over the patient to somebody in the morning. So I'm admitting the patient right now as the emerge doc. Maybe I take care of my patients overnight and transfer in the morning. So I can do handover as directed. I'm going to hand over my MRP status, not the consult, the MRP status to my friend Dr. Smith tomorrow. Yeah, and it's going to put that in here, and I hand it over to Dr. Smith tomorrow at 7 o'clock in the morning. So that's a nice way to get the clerk to switch that patient over to Dr. Smith tomorrow so that it will now be on Dr. Smith's sheet, okay? So we go through, fill out my usual admission order in terms of what I want this patient to have. I'm just going to make sure we don't do any, need to do that because it's going to be on the enoxaparin. Bixaben, we're going to give him some antiemetic because he has been a little bit nauseous. So I'm going to put some PO Zofran as needed. And then we're done for my admission orders. Pretty simple admission orders. Maybe we'll repeat the CBC in the morning. And that's it. So now I'm going to go and preview. So I've reconciled the home meds. I've reconciled the medications that have been done in the emerge. I've cleaned that up. I've added my new admission orders. And now I'm just going to preview it to make sure I'm happy with everything here. So I held my aspirin, I held my naproxen, I've continued the Bixaben and the metoprolol from the emergency department. I've added Zofran new for this patient for the nausea. There's the admission orders that we put in for the patient, including the handover tomorrow, some blood work in the morning, and then here's the home meds. And we'll talk more about that, or Jill will talk more about that, but I've reconciled the home medications. Now, what often will happen is with these home medications, pharmacy will, depending on your site, will review this and kind of look at the patient's medication history and what have you. Or if you have a basic medication BPMH done and it gets reconciled or gets another set of eyes on it by pharmacy the next day, if they make any changes to the home medications, Jill's going to talk about how that looks on your end so that you are aware that there's been a medication change there. And it's really important that when you're doing your admission, that the medications are put in as home medications and you don't put them in as straight orders. So if you just put in the ramipril, you enter all these manually as orders rather than doing them as home medications, it just makes the process downstream a lot harder in terms of when you do your discharge summary, tracking changes that have been made to the home medication so that when you print the script, it shows it quite nicely for the patient. And then less work for pharmacy to have to link these to home medications afterwards. All right, so I'm going to submit that. And I got my little orange flag. Now you notice I didn't have to put my PIN number in. That's because we're testing something right now, but normally you would have to put your PIN number in. I got the little orange flag, so that means we did everything right. We've got our admission transfer orders in there, and it's just waiting to be processed. So in the background, just for those wondering what happens, this notification goes to the appropriate areas, clerk registration, to have them get an account ready, an admission account. And then what they do is they process the admission, the managed transfer. This little orange flag disappears, and then all these orders that we did get moved over to the inpatient account because right now they're still on the ED account. Okay, so ED account, managed transfer gets processed. All of our orders get moved to an inpatient account. If you want to make changes while the patient is still in the emergency department and still has not yet been admitted, if you go to try to enter new orders, it's going to ask you whether or not, oh, I hit the wrong button there. It's going to ask you whether or not the orders are going to be straight orders or are you going to add them to the managed transfer. So if the patient all of a sudden is having some pain, I want to give them some dilaudid, and they're still in the emerge, I'm going to add that, and you're going to notice here it brings me to the managed transfer because I need to decide what to do with that dilaudid when the patient gets admitted. So if I go down to my visit medications now, you're going to see the dilaudid hasn't been dealt with. So they can stop that on when the patient gets admitted. That's just for the emergency department. I'm going to resubmit that. All right, so I'm happy with my patient. The admission's all ready to go. And then through the magic, as Jill kind of compared it to on these TV cooking shows, we're going to magically move our patient from the admission to having had a great stay in hospital, and we've done great care with them. And now we're going to go through the discharge process of this patient. So Jill, I imagine you would want to share your own screen, so I can stop sharing. And I'll let you introduce yourself and load up the screen.
Thanks, Derek. Hi, everybody. So my name is Jillian. For those who I have not met yet, I am a member of the the pharmacy build team. I've been with One Hits through the founding site go live, and I continued on operationally. So I do have a good number of years under my belt dealing with medication reconciliation and discharge issues. So hopefully I'll be able to address any questions you have at the end of the presentation. So I'll just go ahead and share my screen here. Perfect. I think everyone should be able to see that now. So the first thing, and thank you, Derek, for admitting the patient, and through TV magic, the patient's been admitted, had a great stay, and now we're to the point of discharge. But before we get there, I wanted to just point out a couple of things for the web acute status board, so the inpatient side of things. So similarly to the indicator that Derek pointed out in the ED, you'll notice on the left-hand side of the physician status board, we still do have that BPMH status. There's 3 different statuses available. So one would be home medications not updated. This means those medications had not been touched for this visit. That may mean it's from a previous visit for this patient. And the longer you're with Expanse in the system, you'll notice more and more of that type of status appearing where someone's re-presenting to hospital later down the road, and they have home medications already started from the last visit that need to be updated. There also is the home medications not confirmed status, which would mean that someone's got in, they've made some edits, but they've left them in an unconfirmed status. So that will let you know that, we started working on this, but they're not quite ready yet. They're not quite confirmed. Maybe they need a second check by a BPMH tech. Of course, there's also the home meds confirmed, which lets you know they're good to go. Also on the physician status board, the second column is our reconcile indicator. So this one is super handy for a couple of reasons. So for my demo discharge patient, I can see that the MedRec is actually complete. Dr. Garnetz did a great job in doing that, so I can see it's in green. But a couple things I want to note. So I see one has been changed. So that orange indicator here, what that actually means is since Dr. Garnetz has gone in and continued that medication, someone's come and corrected the BPMH. So that might mean the dose is wrong, the frequency is wrong. There's something about that medication that's changed, and it's already actually been ordered on the patient. So that's definitely a flag that physicians are going to want to pay attention to, because that's something that they may need to fix on the patient. They may need to adjust the dose, or they might decide to leave it the same. And I'll show you where you can do that in the orders. Another really good one to note is this held. So I can see that when Dr. Garnetz completed the MedRec on admission, he held 2 of the home meds. Why that's important or relevant would be throughout the patient's stay, the MRP may want to make note of saying, this person has meds on hold from home. Maybe it's an anticoagulant in some cases. I might want to check back in on those 2 home meds that are held to see if they need to be restarted at any point in the visit. So this indicator is just good to keep an eye on throughout the course of the stay, just to see, has things changed or are things on hold that may need to come off hold. So with respect to the BPMH changes after reconciliation. And this is quite common. This will happen, that we'll do a BPMH, things will get reconciled, and at some point, a discrepancy in the BPMH is discovered and corrected. So you see it in the indicator there, but on the orders tab of the chart, providers will also notice that these little houses that indicate these are home med orders turns yellow. So if you click on that yellow house, they're going to get kind of an overview of what's changed. So it's going to say home medication changed. In this case, the amlodipine was initially recorded as the patient was taking 5 milligrams a day. That's what was reconciled in, 5 milligrams a day. But actually, the patient was taking 7.5 at home. So they were taking a higher dose. So if I was a provider in this case, I could look at it and say, you know, I've added metoprolol, or in this case, in TB Magic, I added bisoprolol, but I added a beta blocker. I'm actually okay keeping it at the lower dose. I don't want to make an adjustment to the visit med. In that case, all you would do is click review and say, I looked at this. I'm good with it. I'm not changing anything. If they did want to change the dose, we would have to actually click this and change the dose to what we want. But the key here is that we're adjusting what was ordered for the visit. We're not adjusting the home med that's already been corrected. So in this case, I'm going to just say I reviewed it. I'm happy with it as is. I don't want to make a change. But once that's marked as reviewed, that house will turn black. And that is available in the audit trail as well. So you can see that a physician has reviewed that discrepancy and dealt with it. Just one more thing on this tab is another handy thing is on those houses, you can actually click on them and they'll pull up the home medication detail. You can see how it was entered, who entered it, what sources they were using, any other notes. You actually could also click this all option. And if this is a medication that the patient's been on for a while through multiple visits, you can see the whole history of the med if that was of use to the provider. So I think that's what I wanted to show you there. So we'll move on over to the discharge. Okay. So when the patient's ready to go home, ready for discharge, providers will have to do a discharge med rec. I'll quickly just add a discharge order. I know Dr. Garnis will go over some additional discharge pieces with the discharge summary and all of that, but I will go ahead and submit this. Okay, and now I'm ready to do my prescriptions. So you're going to click on the word prescriptions, which is going to launch you into the medication reconciliation screen. It is quite similar to the reconcile screen on the order tab, but it does function a little bit differently. So things I like to point on in this tab is home medications will always be on your left-hand side of the screen, and visit medications will always be on the right side of the screen. They default to sort by generic name, which is generally the most common of how I find providers prefer this. But there is the option if you wanted to say, you know, I want to look at all of my antihypertensives and cardiovascular drugs together, you can actually change the way this sorts. So you can sort it by drug class. You can also sort it by trade name. I don't find that super popular, but definitely options if it is a preference. I'm going to put this back to my preferred, which is generic. And the other thing that I find is really handy, particularly if your patient has lots of meds on it. You can see that this is a big screen and there's lots of scrolling. So sometimes it's hard to get an overview of the actions that you're going to need to take on discharge. So what I like to do on some of those patients that have lots and lots of meds, I actually like to collapse my view and have a good look at it before I start. So I can see exactly everything the patient's taking, and I can kind of make a plan of how I'm going to go through things and do things that way. And what you'll also notice on this screen is generally how things are organized is home medications that have not been reconciled to visit medications. They're not attached to anything. They're on hold. They'll be at the top. Then home medications that do have an accompanying visit medication through a reconcile link will be next. And then at the bottom will be any new meds. Generally, to reduce clicks for providers and to try to make this as efficient as possible, I always recommend working through the home medication side in full first, and then working through the visit medication side. So generally, just go, like my recommendation is go across the page from left to right, reconcile, do everything on the left side and the right side, and then we'll move through the tabs. So in this case, aspirin, the home medication was on hold. It was never reconciled to the visit. I'm going to go ahead and stop this one because, as Dr. Vargas mentioned, they were started on apixaban. Similarly, for the naproxen, this is one that I prefer them not to have. So I'm going to go ahead and start this one as well. So now I'm getting to my amlodipine. And if we remember, this is the one that had that home medication discrepancy. So what you'll notice is the dose is highlighted in yellow. So that's anything highlighted in yellow is to signify there is a change from how they came in on the med to how they're taking it currently. So in this case, the dose is flagged as it's different. It was 7.5 at home, and in the visit, it's 5 milligrams. So now what I would recommend in this case, if I wanted the patient to continue on 5 milligram, the temptation may be to just continue the visit medication and then stop the home medication. That's perfectly appropriate. You can do that. It is going to give the language to the patient to start one new and stop one. Because the other option that I actually find reduces some clicks would be to continue the home med and then just change the dose. So I'm going to just change it to 5. That's going to put it in a different section on the home medication report called change. That's going to exactly tell the patient you're changing from 7.5 to 5. So I find the language is a little bit more clear. You'll also notice when I do it from the home med side, the visit med automatically stops for me. That's one less click that I have to do. I think actually 2 less clicks that I have to do. So that's always welcome. So in this case, I'm continuing the home med. I'm changing the dose to what is appropriate at this time. So it's likely appropriate that I want to give a new prescription for that. So when we're on the home med side, when you continue them, the system will acknowledge that they're home meds, that the patient has an active prescription for this somewhere in the community. They came in on this med, they must have a prescription for it. So you'll notice that this RX pad that controls whether you're prescribing or not is low lit by default. And that's because you might continue home medications and not offer prescriptions and advise the patient to continue the prescription they had from their primary care provider. In this case, I want to prescribe, so I'm going to go hit my RX pad. Now it's highlighted. It's telling me I'm prescribing, and then I can go ahead and add my quantity or duration. So I'm going to give them 30 days, and I'm going to give them 1 refill. But the other thing I wanted to point out here is this RX Now box that comes up, what that does. So this is a box, it's not pre-checked. It's one that I don't recommend checking. But basically that RX Now is an auto finalize of that one specific medication. So the intent would be if you needed to print one single prescription before you finish the whole med rec for any reason, which is not very common, that RX Now allows you to finalize a single med. I don't love using this because I find when we use that RX Now box, sometimes we click some of them and forget some of them, and then the prescription prints out with half the meds because the whole thing's not finalized. So I generally say, leave that alone. We're going to finalize it all at the end and do it all in one fell swoop so we don't miss anything. Okay, so I'm going to keep going down here. So the inhaler, I'm going to continue it. I'm not going to prescribe this one. I'm going to continue it from home. Again, visit med stopped. We only want it continuing on one side of the screen. And then I'm going to get to their PPI. So you can see in this case, it's a whole different drug. And in this case, I can look at the label comment and I can see that the pharmacy did an auto sub for this. We don't have Nexium on formulary at this site. So they subbed it for the Periot, which is totally fine. And now I can make a decision. Do I want the patient to stop their home Nexium or continue their new Periot? In this case, I'm going to continue their Nexium at home. They don't need a prescription for it. The Periot will stop. So I'm just going to continue a few more here. And then the one thing I wanted to point out with the inhaler. So in this case, I'm going to, even though the patient hasn't been taken in hospital, you can look at this last taken and it's going to tell you the last time it was administered. So in this case, I can see it's a PRN med. They're not actually using it in a hospital. This might lead me to believe that they don't need a prescription for it, but I'm going to just pretend in this case, the patient's told me they're totally out of their salbutamol. They would really love a prescription for this. So I'm going to go ahead and continue it. I'm going to continue it with a prescription, but I don't like this inhalation. So unfortunately, some of these home medications, once these are converted to prescriptions, we don't have a lot of control of how this dispense unit defaults. It's how they're built in the background, and we're unable to change them. It's not really friendly to prescribe in the number of inhalations. So if I want to change this to something different, I would click, I want to prescribe it by the device, so the whole inhaler. So I can put that I want to give 1 inhaler. Otherwise, if it was a scheduled med, I can certainly put a duration. But in this case, I'm going to do It's a PRN, so it's easiest if I just say they're going to get one inhaler, one device. And I, again, highlighted my RX pad, so that's a prescription. Okay, so I've dealt with all my home medications on the left-hand side, which is great. So now I'm down to my new medications, visit medications. So in this case, I'm going to click apixaban. This is important for them to continue. And the difference I want to highlight here is when it's a visit medication you're continuing, the RX pad automatically illuminates. This is, again, because we're telling the system this is brand new for the patient. They didn't have this at home. This is new from hospital. So it's assuming that they're going to need a prescription. You don't have one in the community somewhere. So you can go ahead and click new. That's already highlighted. So then I can go ahead and add my quantity duration here. I'm going to get a refill. Similarly with my beta blocker. Again, I'm leaving that RX now alone. We're going to finalize at the end. And now I'm getting to some other visit medications. In this case, it's a Bauer protocol, but these are things that I don't think the patient needs to continue. Again, I can look at that last taken date. I can see what they were using. I can also see if this visit medication was on hold. So this is a good field to just pay attention to as we're working our way through. So in this case, I'm going to stop the glycerin. I can see they actually were using the PEG, so perhaps this is something I want to continue. And what I wanted to flag here is you can actually unselect the RX pad. So Meditech calls this an OTC or over-the-counter prescription, where I'm telling the patient, you can go ahead and take the laxative, the PEG. It's not going to be covered under your plan. We're just going to assume that in this case. So I want you to buy it over the counter. I find a lot of providers like this for things like vitamins and things that are tricky to prescribe, that they'll just unselect that pad and say, continue your vitamins at home, you can buy those. And that prevents you from having to deal with things like the dispensing unit or the quantity and duration. So just another tip there. And then I'm going to go ahead and stop these other ones. Okay, so I've done my whole med rep. So again, working from left to right, I'm going to click add new. And what I wanted to point out here is you do actually have the option to set up some prescription favorites. This may be more handy on some services or in some specialties than others. For example, for an orthopedic surgeon who is often doing anticoagulation and pain management, they might set up some favorite prescriptions for them. In another service where it's very variable what you're prescribing at discharge, may not be as handy. But just wanted to point out that you can certainly set up prescription favorites and you can complete them as much as you want. So in this case, for this amoxicillin, the entire string is completed with, I typically like to prescribe it TID for a week. So that's done. Or I can do things like put the dose and leave the quantity in the refills blank so that I can just fill those in for each specific patient based on their need. So it's just an option if some providers find that helpful. But in this case, I stopped their naproxen, so I'm going to just give them some Tylenol instead. So I'm going to just pick the string that is the closest to what I want, and then I can go ahead and modify that. So I want to give them 1,000 milligrams 3 times daily as they need. I'm going to give them 100 tabs, and I'm going to say that's for pain. If you were prescribing more things, you would hit Q. In this case, this is the only thing new I'm prescribing, so I'm going to click Q and exit. And most importantly, always, always, always preview. So this is going to give you a really good overview of what's new for the patient. What are we continuing? Again, doing that change from home puts it in this change category where it's saying it's changed from 7.5 to 5, and what's stopped. The other thing you'll notice here is it's going to tell you what you're actually prescribing by checking that RX pad. So this is a good double check of saying, is there anything else I need to prescribe for this patient? Are they out of their Crestor and I want to go back and prescribe that? You can just go back to reconcile and make that change. So this is a really important one to just get an overlay of, is it the way I want it to look? You'll also see if you've missed any, a no action section there. So obviously if you have things in no action, those are things you likely want to go back and deal with. So I'm happy with that. So I'm going to go ahead and submit it. Okay. And again, this is going to be laid out similarly to that preview screen where it's going to say, these are new. I'm giving 3 new prescriptions. Again, I decided to do an OTC prescription for the laxative, so I unchecked that pad so that actually won't print as a prescription. And then which ones I prescribed from home and which ones I stopped. There also is this notes to community pharmacy field. So the use of this field will put a note on the prescription. We recommend using this field when it applies to all medications on that prescription. So say it's a compliance pack patient who you want to say, please, compliance pack these medications in every 2 weeks for this patient to help them with their adherence, something like that. If it's something like specific to a single med, like a narcotic dispensing interval, I would just put that as an RX instruction within the medication itself because it only applies to a single med. So again, these would be notes that apply to the whole lot of the prescription. So I'm going to have a look here, make sure everything looks the way I want it to look. And very importantly, I need to finalize it. Why that's important is until you click that button, everything's kind of saved in a draft state. And I'm just going to show you. You'll notice I can't print the prescriptions in the home ed reports because they're not final. Why that's really handy is say that you have a patient who's going home, they're a really complicated patient, the discharge med rec's going to take you a bit. You can queue that all up, get it all ready to go, and then say the next day the patient's now ready to go home, you can just now at that point finalize it or make any last minute adjustments. Once you finalize it, things can still be adjusted, but it just becomes a bit trickier, a bit more click. So I usually recommend hitting finalize when you're pretty sure the patient's ready to go, you're ready to print the prescriptions. That's the point we want to do that. So we're going to click finalize. It's going to say that we're confirming this is the correct discharge medication list. I'm going to say yes. Awesome. It's going to tell me that I finalized it. And now when I go back to the print section, you'll notice that I have both the home medication report and the prescriptions available because that step has been done. So it's just a good cue. If you're unable to print something, it might be that that step was missed and we have to go back and do it. That red finalize button is kind of connected to this patient disposition. We don't recommend updating the disposition first for that reason. So if this disposition gets updated to private home, the red button is going to disappear. The prescription can still be finalized, but you'd have to go back into the MedRec and click the finalize button from in here. So generally, I just recommend that discharge position is one of the last things you're going to do when the patient's going home, to leave the default as it is, because it's going to allow this to function better for your providers. Okay, so now I need to print. So a really important thing to know about prescription printing is that it works off physician print preferences. A lot of patient reports will print to the patient location. Unfortunately, it's hard-coded in Meditech that prescriptions work a little different. They print to the provider preference. And the logic there is really just, the provider might be in their office. They may not be on the floor where the patient is. So they want the provider to be able to determine where it should go. So providers can set their print preferences in their menu. Set that here. The other really important tip I like to give people is those print preferences are actually set by computer terminal you're using. Again, for the same logic as when you're sitting at one computer terminal, you may want it to go to the closest printer there. And if you move to a unit and you're sitting at a different computer, you might want a different preference. So you might hear providers saying, I've had to set my print preferences several times. That is accurate. It's something that we wish we could change and are able to at this time. But once you set it for that one device that you usually would use, it's set there. But just in case providers are indicating, my preferences aren't sticking, they're not saving, it could be that they're at a new computer for the first time and they might need to reset them. Okay, so in this case, I'm going to go to save and print. I always like to personally recommend printing both the home medication report and the prescription because the home medication report does contain very important information that the pharmacy does need to know, like what medications are stocked. And I find when the providers print them together, it does ensure that they go to the pharmacy together. Otherwise, the nurse and clerk can print them, but they would have to remember to print them and send them with the prescription. So this is just a safety thing. I find when providers click both together, they tend to go to the pharmacy together. So something I like to recommend. So I'm going to click print. And what I want to flag here is you're going to get two print previews because they're two different reports. So the discharge packet report, I'm just going to preview it instead of print, just so we can see it. I'm going to give it a second to load. Okay, so this is my pretty home medication list where I'm going to get all of my new medications. Anything I prescribed has that RX symbol. Again, that laxative on there is new, so the patient knows that they should take this, but there's no prescription, so they can buy it over the counter. What they're continuing at home with what was prescribed, what was changed. So again, stop taking 7.5, start taking 5. We did give a prescription for that, as well as importantly, what was stopped. So this is a report that I do recommend get sent to the pharmacy, as well as a copy is given to the patient in their discharge packet. And then they get to the screen and it looks like a duplicate, but we'll notice that this is actually now the prescription. So if you are printing them, you're going to have to hit OK twice to get both reports. So now we'll just wait for that prescription to pop up here. And then we get our prescription here. So this is going to just have the 5 prescriptions we're prescribing. Everything else, all the other information is contained on our report. So then we would print it and sign it and provide it to the nurse or the clerk to be faxed to the pharmacy or to be given to the patient. So that's kind of a quick overview from top to bottom of the discharge. I think, Derek, you wanted to also go through some of the other summary pieces before we take questions?
Actually, no, it's just more the discharge summary part. So if you just want to click on document and the discharge summary, I just want to kind of make one comment here. So we recommend the discharge process starts by opening a discharge summary. And why this is important is because you can, if you don't have time to finish the discharge summary, you can always save it. And then you can go back to it. But if you open the discharge summary first as your discharge process, you can do the exact steps that Jill just showed by going to the bottom of the discharge summary, and you'll see that prescription area there. So you don't have to necessarily, we recommend doing that through the discharge summary, just because it kind of reminds you to get the discharge summary done as well. So I just kind of wanted to point that part of it out. So that, yeah, that was great, Jill. I really appreciate that.
Can I add one more thing, Dr. Rosenberg? So the only other thing I wanted to add about that discharge summary is how the medications are laid out, that new, continue, change, stop, that will flow automatically into your discharge summary as long as it's not signed yet. So if you sign your discharge summary and then you do your med rec, that information won't populate, because once it's signed, the document's final. You can certainly start it, keep it in draft, do your discharge med rec. If you make any changes, those will continue to pull into your discharge summary until the point it's signed. The medication changes will stop flowing in. So just a tip about that.
Yep, excellent point. Excellent point. Great. I'll just take over your screen for 1 second. Just want to give one quick comment about Prescribeit, and then we'll open it up to questions to myself or Joe or the team. So Prescribeit, everybody, when we talk about discharge prescriptions, want to know about sending them electronically. And I know many people who have office practices on TELUS or Oscar, whomever you're using, this is pretty common. And it's why don't we have it at the hospital? So the limitation is not Meditech. They do this all the time in the United States. The limitation was mainly more how we integrate with our community pharmacies in Ontario. So you've probably heard about Prescribeit. Prescribeit is Canada's prescribing platform, essentially. So it allows for the electronic prescriptions being sent to pharmacies, being able to create the script, send it to the pharmacy gets it, and back and forth communication related to that. So this is being used in Ontario. Humber River Hospital is a pilot site. They're doing this right now. And with Meditech, so they're the pilot site with Meditech using Prescribeit. It uses something called Dr. First in the background. Dr. First is a platform that expands from Meditech with the Prescribeit platform. And Meditech is working on getting connections with the DHDR so that we actually get a medication history that can be consumed and reconciled as well. From the patient's DHDR, which is the Ontario repository for the drugs that patients are prescribed. Because Prescribeit, although it's great for writing prescriptions and getting them sent electronically, it doesn't provide a medication history. So Prescribeit, we're well aware of the need for this. It is on our OPIC, our OPIC agenda, the Innovation Committee regionally. We have this on our radar. We're doing some deep dive into it. But currently, like I said, their Meditech is working with Humber River Hospital, and there's a couple other hospitals that are on the map to be the next to go live with it. But it's still working through the process right now of going live in Extend. So coming down the pipes, and we know this is a priority that's been we've been made aware of by the clinicians as well as by the hospital administration. So that is coming down the pipes. All right, so we'll open it up to any questions people may have. I haven't been watching the chat, so I apologize, but I'm sure Julie and everyone's been keeping up there. But any questions that people may have? With the managed transfer and the admission process, I'm surprised all the hands aren't going up. Maybe we're all amazing with the managed transfer now. Yeah, I heard it. Is it Lady Dunn, I think? Yes, go ahead.
Yes, Dr. Gardas. For the completion of the discharge medication rec and prescription, for the part where it says stop medications, we've been asked by pharmacies to actually, the doctor has to sign that to stop medications. That's the only place that it's sent to the pharmacy, correct?
I can answer that. I'm a little bit surprised they're asking you to sign it. I'm a community pharmacist myself. I still practice in the community. I would say the founding sites have not had that experience where community pharmacies are requesting them to sign the home medication list. You certainly could, but I don't know if that is actually a conversation that could be had with the community pharmacies through your pharmacy department, just to see if it really is necessary. Again, they're not, because you're not prescribing anything, you're just indicating that those things can be stopped. So legally, it does not require a prescription, so it might be a preference of those pharmacies, if that's helpful.
Yeah, we'll reach out to our pharmacists then and just have a discussion.
Yeah, and if they have questions, they can certainly reach out to myself as well, or even I always reach out to our pharmacy college when I have practice concerns, just to get their take on it. But happy to assist in those discussions if it's helpful.
Okay, thank you.
Jill, two questions came up in the chat. So one is, do IV antibiotics flow to the visit medication for DC rec? And if they can be switched to PO. And the second one is, could you repeat the advice about altering the script after finalizing?
Yeah, so the first one, good question, James. So that one actually is just before PAC, the Physician Advisory Committee right now. There are the pros and cons to the IV antibiotics showing up in the discharge metric. So just historically for the founding sites, we did review the functionality in Meditech and we had decided to turn it off. There were some safety concerns at the time about doses not being converted correctly for narcotic infusions, which posed some patient safety risks. We do now have a solution to that. So we represented it to the Physician Advisory Committee. So right now it's going to a decision document, and sites can decide if they want that to be turned on. Just very quickly, some pros of that are obviously it gives you more information on the patient so you can make the determination to do an IV to PO. The cons are, even if you prescribe IVs and expands, you do need to still complete all of the paper prescriptions and forms for home care in the infusions as well. So some providers find it a little bit duplicative where they have to do it twice. So pros and cons, and sites will be able to decide, but that is before PAC. So stay tuned on that one. And then could you please repeat the advice about altering the prescription after finalizing? Yeah. So we can certainly alter a prescription after finalizing. I'll share my screen just quickly again here. The main thing to know is it becomes a two-step process. So you first need to cancel the prescriptions that are already finalized, and then you need to go back and re-prescribe them. So you have to do two separate submissions basically after it's been finalized, which is kind of why it's a pain. So in this case, for example, say I want to change the amlodipine. Actually, I do want them on their 7.5. You'll notice the only option I have is to cancel it. So I can certainly go ahead and cancel that and do doctor's order. I can submit it. And then if it is a visit medication, what you'll notice is now that I've stopped it, that was a home medication. So that was a bad example. So with the home medications, I've stopped a home medication now. So it's gone, like I've stopped it. So the only way to now adjust this one would be to prescribe it new. And then I'll show you what happens when it's a visit medication. So you just have to kind of keep track if they're home medications or visit medications. So say in this case, I actually did want it to be 7.5. Oh, no, that's not what I wanted. and I'm going to give them 60 tabs. Okay. So then I'm going to prescribe this one new from scratch. And then you'll see that it's telling them to stop their homomodipine and to start a new one up here. Similarly, if it's a visit medication, it's a little bit easier. So one of the visit medications I prescribed was a Prescribelt. So if I wanted to change that dose, say it needed to be dose adjusted now, I'm going to just go find it. I'm going to cancel it. Dose change. I'm going to have to submit it. And then I have to go back in and make the adjustment. The benefit with when it's a visit medication, as long as the patient's still admitted and it's still an active visit med, it actually will just reopen with a new continue stop button. So if you stop a home med prescription, something that they came in from home and you prescribe from home, you might have to add new. If you stop a visit med one, it should reopen back for another decision. So now I can continue it and do whatever I want with it, change the quantity or the dose. So the process again would be you have to go into the discharge med rec, cancel those prescriptions that are no longer what you want, and then add them back new or make new decisions on them. So a two-step process. Hopefully that helps.
That's great, Jill. Just as we get close to the 9 o'clock hour, we're going to take some more questions, but Maggie, so those that are still on the call, do you want to give any comments about how to access the recordings and tip sheets? Because I know that's come up as a couple questions and some concerns about not being able to access it.
So we're doing our best to help with the access. It's always an issue when it comes to the drive, especially those who don't have accounts. I am going to possibly recommend site leads also, possibly download a local copy. I'm going to look into seeing how we can make it a little bit more accessible. We'll continue to build it into the folder, but please be patient as we try to kind of work through the requests and see if there's another solution that we can bring forward. There's just always a limitation with our Google access, especially with any care accounts, which I know there's a lot. So even if you have a Google account, it still can be an issue with access. It's more having kind of those any care Google accounts. And this is something that we continuously run into. So I'll continue to work on that piece.
And Maggie, we'll talk about it later on today. We can maybe put it on YouTube, like with the CMIO channel. So the one thing with the YouTube videos is that if we put this out there, it's public. So we can share it in a way that it's a private link. But if you share the link with anybody else, they could have it. But maybe we'll do YouTube because it might make it a lot easier for everyone, so you don't have to log in to see it.
Okay, sounds good.
And I do see one more question from Akriha about nurses reprinting. So inpatient prescriptions, the only provider access group that can print prescriptions are providers. Reason being is they do need to be signed to be legal valid prescriptions. So if a nurse were to reprint them when the physician's not available, they would have no way to sign them. I have had sites who are able to, depending on the situation, if the prescription was misplaced, like the pharmacy lost it, once it's scanned into the system, you can reprint the scanned image of the prescription. That can be found under historical orders after the patient's discharge. So that's an option, but otherwise currently only providers can print prescriptions. Looking forward to Prescribelt, only providers will be able to transmit those, so it'll be a similar workflow. Hopefully that helps answer the question, Akriha, but feel free to reach out if you have any more concerns or questions about that.
Are you saying that the nurse cannot reprint the prescription from the discharge area? They only if it is scanned in, they would be able to go and get it from there? Is that what the explanation was?
Correct, yeah, that only providers can print prescriptions out of the discharge.
Okay.
All right. Any other questions, feedback? We're right at the top of the hour, so that's perfect timing. I just want to thank Jill again for a fabulous presentation on that. You make it look very easy, and it's nice to see some of those parts of discharge script. You know, I don't do that very often in my role in the ED, so it's nice to see some of the changes in the functionality that Meditech has done over the years. So thank you for that. And thank you to Maggie and Julie for all the background work and getting these sessions set up and all of the logistics of that. So we appreciate that. So yeah, we'll give it another minute there if anybody has any further questions. Otherwise, we will wrap up the session, and we look forward to seeing you at our next session next week. I will get out the information about the quick text examples that I promised I will send out, and just collecting those from other people as well. So we have a really robust set of them to share. And please provide feedback in terms of the next session, future sessions, because I think this has been very helpful, and we're really excited about the number of people that are attending this. Yeah, so if there's no further questions, then we'll wrap it up. And thank you, everybody. Have a great day, and we'll see you next week, same time, same place.